It's a privilege to continue this two-part presentation titled Breast Cancer Cryoablation, a Practical Guideline for Patients and Physicians. This is part two of a two-part presentation. The first presentation, which is available in a separate video, discussed the initial diagnostic workup and pre-treatment planning of patients considering cryoablation. The second part would focus on treatment approaches and post-treatment follow-up. As I mentioned in part one, the best outcomes from cryoablation are achieved when the surgeon's mindset is brought to the procedure. For both cryoablation and surgery, successful treatment requires a comprehensive understanding of the three-dimensional extent of the cancer, including the location and distance of any adjacent satellite tumors, the location of any suspicious calcifications that may extend beyond the main tumor mass, as well as the presence of subtle changes in the tissue texture around the main mass that might suggest a more extensive process. In contrast with surgery, where a 1 millimeter microscopic margin is considered acceptable, the inability to perform microscopic margin assessment with cryoablation calls for the provider to cryoablate an even wider gross margin, ideally 5 to 10 millimeters beyond the edges of the cancer, the goal of which is to minimize the risk of leaving untreated residual disease in the perimeter of the main tumor mass. Now, in the next few minutes, I will discuss targeting the tumor for cryoablation, but before doing so, there are some definitions you should it would be helpful. Now, in the next few minutes, I will discuss targeting the tumor for cryoablation, but before doing so, it would be helpful to learn the following definitions. This image shows a cryoablation site that was removed with lumpectomy a few weeks after cryoablation. The pink area in the center is the cryoablation zone of necrosis, which typically has a maximal volume of 4 by 3 by 3 centimeters. Within the green area, just outside of the zone of necrosis, is an area that is injured but not killed. And this corresponds to the ice ball that is created at the time of cryoablation, generally 5 by 4 by 4 centimeters. And then lastly, there is the slightly larger yellow zone of inflammation, which includes an area around the ice ball where inflammation is observed, but there's no cancer kill effect in that area. Modern technology for office-based tumor cryoablation is optimized for treatment of a single tumor less than or equal to 2 centimeters, which can easily be achieved with a single cryoablation zone of necrosis measuring 4 by 3 by 3 centimeters, shown here in red, which requires a zone of injury or an ice ball volume of at least 5 by 4 by 4 centimeters. Therefore, in the example shown on the slide, the brown tumor here, which measures 2 by 1.5 by 1.5 centimeters in this example, when ablated with a 4 by 3 by 3 centimeter zone of necrosis, would achieve a gross surgical margin of 0.75 centimeters or greater. Typically, 2 10-minute free cycles are required to achieve a cryoablation zone of necrosis of 4 by 3 by 3 centimeters. Although the actual ice ball dimensions and shape will vary by the length of the free cycles as well as by the cryoprobe design, the competing warming effects of the normal body temperature make it difficult for a single cryoablation to achieve a cryoablation zone of necrosis greater than 4 by 4 by 3 centimeters, even if the freeze time is lengthened. So there is some constraints. The design of the current system, the tools that we use, the cryoprobe, is sort of optimized for treating tumors 2 centimeters or smaller. But even if we wanted to treat a larger tumor with a single cryoablation treatment, we're limited by the fact that we can't create a larger ice ball because the body tends to warm the breast, or the body tends to warm or compete against the ice that is forming in the breast. And in this competition, the warming of the site by the normal body temperature is what limits the ablation volume of a single ablation. Now, although multiple cryoablation systems exist, the more user-friendly office-based system utilizes a single disposable cryoprobe through which liquid nitrogen circulates during cryoablation. However, we do have the ability to perform multiple consecutive overlapping cryoablations to achieve a larger volume of necrosis, and then is achievable with a single ablation. So, although I said there's a limited volume that each ablation can achieve, as you'll see in a moment, you can combine multiple ablations overlapping to treat a larger volume of disease than you can treat with a single ablation. The classic example of that is this image, where we use 2 overlapping ablations to treat a tumor, which not only treats the tumor but also potentially achieves a wider margin around the tumor. Although multiple treatments are possible, one disadvantage of multiple treatments is that it takes longer. Each cryoablation takes about 30 minutes. So if you do 2 overlapping cryoablation, that's a 60-minute treatment at least. And if you do more ablations, then it's that number times 30 plus additional time it may take to prepare for each ablation. The second disadvantage of the using a single probe to perform multiple ablations is that there is no clear guidance from the manufacturers on how much adjacent cryoablation zones should be overlapped in order to prevent undertreatment of skip areas of disease between adjacent zones of necrosis. However, in my judgment, when using cryoablation zones of necrosis measuring 4 by 3 by 3 centimeters, spacing each adjacent cryoablation site 1.5 centimeters from the next one minimizes to a reasonable degree the risk of leaving incompleted ablated cancer cells between and within overlapping cryoablation zones of the necrosis. So essentially, what I do is I insert each cryoprobe 1.5 centimeters away from the previous insertion site, so that there's generous overlap between the first cryoablation site and the second cryoablation site when multiple cryoablation zones are needed to achieve complete ablation of a larger tumor or of a smaller tumor with a wider margin. Therefore, using the 1.5 centimeter spacing principle and cryoablation zones measuring 4 by 3 by 3 centimeters, cryoablation of a 4 by 2 by 2 centimeter cancer with a minimum goal margin of 8 millimeters will require 3 overlapping cryoablation zones of necrosis to accomplish complete ablation with an adequate margin. By contrast, ablation of a 4 by 4 by 4 tumor with a 1 centimeter surgical margin will require at least 6 overlapping cryoablation zones of necrosis, which significantly increases the complexity and cost of the procedure. Here's a real example of a cryoablation procedure requiring 4 overlapping cryoablation zones of necrosis with cryoprobe spacings of 1.5 centimeters. Here's another such patient who presented with multiple tumors in the left breast upper outer quadrant, for which mastectomy was recommended but refused. She subsequently underwent successful left breast cryoablation using 4 separate but overlapping ablations of the upper outer quadrant to treat 5 different cancers, as well as the intervening tissue, which is also likely at risk. To date, the patient has had no evidence of recurrence, so the treatment was successful for her. Another point that needs to be considered is the fact that successful cryoablation means that there will be no residual tissue available for pathological assessment after completion of the cryoablation procedure. Consequently, the physician performing the cryoablation procedure should consider whether or not additional biopsies of the tumor should be performed immediately before performing the cryoablation procedure, because that might be the last opportunity to get viable cancer cells, particularly if the sample in the lab from the previous biopsies is inadequate. So potential reasons for performing additional biopsies at the time of the cryoablation procedure include each of the following. Number one, we do it because we can potentially obtain additional tissue if needed for genomic testing. It's done to check for the presence of residual disease at the tumor site after completing upfront chemotherapy or upfront anti-HER2 therapy, because the presence of residual disease has treatment implications. And the third reason is that it may be used for wider sampling of the area of disease to determine if there are any parts of the disease that may be under-assessed. For example, for a patient with a lower span of DCIS, although her primary diagnosis is stage 0 breast cancer, performing multiple biopsies across the span of the DCIS might find small areas of invasion that would change her stage from stage 0 to stage 1. In most instances, ultrasound alone is sufficient for locating and guiding cryoablation of an ultrasound-visible tumor. However, when the cancer exhibits features that are not fully ultrasound visible, like calcifications or mammographic densities or MRI enhancement, then, as you learned in part 1 of the presentation, mammography-guided or MRI-guided insertion of an ultrasound-visible biopsy site marker provides a surrogate target for locating and directing the cryoprobe for ultrasound-guided cryoablation. So even though the tumor might not be visible any longer, placement of an ultrasound-visible marker can help to identify it for cryoablation. This point should be clear. There also are situations where if the span of disease is broad, it might be necessary to place more than one ultrasound visible marker to bracket the area of disease. And that situation is shown in this image, where you have the original biopsy site, but there are calcium deposits extending in this direction, and so in order to ensure that the full span of the disease was identifiable and targetable with cryoablation, I had the radiologist place additional markers at the left and right edge of the calcifications in order to ensure the proper and comprehensive treatment of that site. Similar to surgery, when the span of the disease, I just made that point. So, in the next slide, I'd like to talk about a problem that is sometimes encountered in breast surgery and breast radiology, and it's called clip migration or marker migration. When a biopsy clip or marker is inserted at the time of the needle biopsy procedure, the clip may sometimes migrate or move along the needle path 1 or 2 centimeters away from its intended location. Clip migration greater than 1 centimeter occurs in about 20% of biopsy procedures, and is most likely to occur when clips are placed under mammogram guidance or under MRI guidance, where the location of the clip with respect to the cancer might shift when the breast is released from compression. If the radiologist does not recognize and adjust for clip migration when an ultrasound visible marker is placed or when cryoablation is performed, then there is a risk that the cryoablation might be directed to the wrong site or might be off-centered. So it's really important for the cryoablation provider and the radiologist to recognize clip migration and not pursue a clip that's completely in the wrong position. We'll talk about lymph node surgery now. The goal of lymph node staging is to detect the presence or to confirm the absence of lymph node metastasis. Because of the status of the nodes, because the status of the nodes determines the need for an extended surgery. I'm going to restate that. The reason that we have traditionally performed lymph node staging is because the status of the lymph nodes has traditionally been used to estimate prognosis as well as to guide how the lymph nodes in breast surgery should be performed. Lymph node evaluation has been used to guide drug therapy, and has also been used to assess the extent to which radiation might be needed to control recurrences within the lymph node basin. In general, lymph node management for cryoablation patients should mirror lymph node management for surgical candidates. For example, in accordance with the Society of Surgical Oncology's Choosing Widely recommendations, white women aged 70 and older with stage 1 estrogen or progesterone receptor HER2 negative invasive breast cancer and normal appearing nodes should skip routine sentinel biopsy if they're committed to taking anti-estrogen therapy. Now, the exception to this recommendation includes elderly patients with high-grade tumors, high-risk genomic recurrence scores, or low levels of estrogen receptor and/or progesterone receptor expression for whom the risk of lymph node involvement is higher. On the other hand, women younger than 70 years of age with estrogen receptor positive or progesterone receptor positive and HER2 negative breast cancers and normal appearing lymph nodes should consider undergoing sentinel biopsy. Still, among these patients, there exists a possibility to use genomic testing to identify those with genomic low-risk cancers for whom sentinel biopsy can be avoided altogether if they're willing to take anti-estrogen therapy and have their lymph nodes monitored routinely over time by ultrasound. Conversely, those with normal appearing nodes but genomically high-risk tumors should be advised to undergo sentinel biopsy due to the elevated risk of lymph node metastasis. Among patients who express a reluctance to receive chemotherapy or anti-HER2 therapy under any circumstance, the finding of a positive sentinel might be enough for them to reconsider their withdrawals. Patients with triple negative or HER2 positive invasive breast cancer and normal appearing lymph nodes should be encouraged to undergo sentinel biopsy given the higher risk of microscopic lymph node metastasis and the implications of a positive node on the overall treatment plan. Sentinel biopsy may be performed using a radioactive substance and/or blue dye that is injected into the breast to identify the main pathways through which lymphatic fluid, or possibly cancer cells, drain from the breast to the lymph nodes. Since the dominant pattern of lymphatic drainage passes near the skin of the upper outer quadrant of each breast, the cryoablation provider must consider the implications of cryoablating an upper outer quadrant tumor, since the cryoablation procedure itself might block lymphatic drainage to the sentinel nodes. The photograph here shows lymphatic mapping of the left breast with a fluorescent tracer, which is visible through the skin as this white glow. There also have been corresponding markings on the surface of the skin to show the pattern of lymphatic drainage, and you can see in this patient that the lymphatic drainage again courses through the upper outer quadrant of the breast and again is relatively close to the skin. The typical examples that we see is cryoablation of a superficial tumor along the 10 o'clock axis of the right breast or a 2 o'clock axis or the 2 o'clock axis of the left breast can block drainage of the radioactive or blue dye tracer that's injected into the breast for lymph node mapping. Thus, if cryoablation and sentinel biopsy are planned for a tumor in a superficial location in the 10 o'clock axis of the right breast or the 2 o'clock axis of the left breast, then arrangements should be made by a surgeon to perform the sentinel biopsy procedure prior to cryoablation, or for the patient to undergo tracer injection prior to the cryoablation procedure, followed soon thereafter by cryoablation and sentinel biopsy. For patients with microscopically positive sentinel nodes, the current standard of care is the administration of radiation to the neighboring lymph nodes where the risk of residual disease is between 20 to 40%. Compared to surgical removal of these nodes, treating them instead with radiation has significantly reduced the risk of chronic arm lymphedema or that's associated with complete lymph node removal. So what I'm proposing is, instead of removing the possibly involved nodes that look normal but have a 20 to 40% chance of containing areas of metastasis, tiny areas of metastasis, these additional lymph nodes can be treated with radiation instead of complete removal of surgery, because the addition of radiation to these lymph nodes, even though the lymph nodes are treated, the addition of radiation to these lymph nodes has a minimal impact on the risk of lymphedema, whereas surgical removal of lymph nodes has a significant impact on the risk of lymphedema. Now, for patients with grossly positive lymph nodes that have been confirmed positive by needle biopsy, the current standard of care is either to completely remove that lymph node and the remaining lymph nodes, or to administer upfront chemotherapy and or upfront anti-HER2 therapy with a goal of eradicating cancer from the affected nodes to permit removal of fewer nodes, a concept that we call downstaging. Without question, complete removal of the nearby arm lymph nodes is one of the most feared procedures amongst patients due to the risk of lifelong chronic arm lymphedema, shown here in this image. However, in keeping with the growing trend to minimize the risk of lymphedema and to reduce the overall burden of lymph node surgery, patients undergoing cryoablation may benefit from the following technical modifications of the lymph node surgical procedure. Number one, instead of removing all the lymph nodes, the surgeon would remove only the grossly positive ones, with the goal of leaving all normal appearing lymph nodes intact to minimize the burden of more extensive lymph node surgery. In this scenario, the addition of radiation to the remaining lymph nodes would minimize the risk of lymph node recurrence while also reducing the risk of lymphedema. A teaching point here again is that the remaining nodes have a reasonably high probability of containing additional metastasis, microscopic metastasis, a risk that may be as high as 40%. And if these lymph nodes are left untreated, these microscopic tumor cells will likely continue to grow and give rise to lymph node recurrence or distant recurrence in the next 1 to 2 years. Fortunately, radiation is very effective at killing microscopic cells in the lymph nodes, but even though it's effective at killing cancer cells, it has a low risk it does not significantly increase the risk of lymphedema compared to surgery. So again, radiation therapy for treatment of these normal appearing but possibly involved nodes has greatly reduced the burden of cancer surgery. Therefore, we're able to limit the surgery to just removal of the grossly abnormal node, with radiation administered to treat the remaining normal appearing nodes that might also contain disease. To further reduce the risk of lymphedema from removal that results from removal of grossly positive nodes, the surgeon can perform axillary reverse mapping to help identify and avoid injury to the arm lymphatic drainage at the time of lymph node surgery. Axillary reverse mapping typically involves injection of blue dye into the arm near the armpit. Absorption of the blue dye causes lymphatic vessels and lymph nodes draining the arm to turn blue. The blue staining in lymphatic vessels and lymph nodes may therefore be seen and avoided during lymph node surgery, while the targeted grossly positive node is actually removed. Axillary reverse mapping has been shown to significantly reduce the risk of lymphedema in patients undergoing lymph node surgery, especially when the extent of disease requires removal of multiple axillary nodes. In addition to performing axillary reverse mapping, the skilled surgeon might also perform a procedure called S-Lympha, Simplified Lymphatic Microsurgical Preventive Healing Approach, S-Lympha, to reconnect and restore lymphatic flow if arm draining lymphatic vessels are divided during lymph node surgery. S-Lympha has been shown to significantly reduce the risk of lymphedema in patients undergoing extensive lymph node surgery. Fortunately, I perform both of these procedures, axillary reverse mapping and S-Lympha, and so I utilize them particularly in patients that have grossly positive nodes that require resection. I utilize these techniques to minimize the risk of lymphedema in these patients. Despite the effort to minimize the burden of lymph node surgery, some patients with grossly positive nodes or needle biopsy positive lymph nodes continue to refuse lymph node surgery. In the context of patient-centered care, some of these patients can undergo lymph node cryoablation instead of surgery to eradicate positive nodes. On this slide, you see on the image to the left a grossly abnormal lymph node, this dark round area that's with these hash marks showing that it's being measured. Although you can't see it as well, that same node is undergoing cryoablation. There's a white line which represents the cryo probe, which is passed through the lymph node shown here. This is an image of the lymph node before cryoablation is started. Once cryoablation starts, you're no longer able to see the lymph node. But this again is the snapshot that was taken just before starting the first freeze cycle. Although lymph node cryoablation can be performed, it's safer if only one or two lymph nodes are affected. But just as with surgery, there is a higher chance of microscopic cancer cells in neighboring lymph nodes if cryoablation is performed, and there needs to be a plan for addressing those additional nodes. Radiation generally is the best plan in terms of effectiveness and safety. Lymph node cryoablation is safer if the target lymph nodes are not near the large vessels in the upper armpit, which may prevent the ice ball from getting cold enough due to the high volume of warm blood flow next to the cryoablation site when cryoablation is performed in these locations. Now, unlike cancers in the breast that must be ablated with a surrounding surgical margin, the encapsulated nature of lymph nodes generally eliminates the need for cryoablation of a surrounding surgical margin. However, the elongated shape of the ice ball causes the cryoablation zone of necrosis to extend beyond the near and far edges of the lymph node, which can result in unintentional cryoablation or injury to adjacent uninvolved normal lymph nodes, to adjacent lymphatics, or to adjacent nerves or blood vessels. The other limitation of lymph node cryoablation is that I am not able to perform axial reverse mapping or S-lympha in these patients, since there's no surgical procedure, no invasive surgical procedure being performed to identify the pattern of lymphatic drainage in these patients. Now we move on to talking about anti-cancer medications. Unlike surgery and cryoablation, which aim to treat and prevent recurrence of cancer within the breast, chemotherapy, anti-HER2 therapy, and anti-estrogen therapy, and other anti-cancer medications are given for invasive cancer patients with the goal of improving overall survival by preventing growth of microscopic, hidden metastatic tumor deposits that might already exist in the lung, liver, bone, brain, and other sites. The probability of having distant metastasis increases with higher cancer stage and increases with more aggressive tumor biology. Depending upon the stage, tumor metastases originate from the breast tumor long before the breast cancer diagnosis is made. The bigger or the more aggressive the tumor at the time of diagnosis, the more likely metastases have already occurred. Fortunately, not all metastases have the ability to grow and thrive, but we must at least acknowledge the possibility that some may have the ability to grow and thrive. However, because of the microscopic size of these metastases when they spread, they're virtually undetectable by CAT scans, PET scans, and other body scans. So that's why we generally don't recommend total body scans for these very early cancers, because even though they might be metastasis, they're exceedingly hard to detect initially, and therefore scanning these patients has very little utility. However, in the absence of effective anti-cancer medications, these microscopic distant metastases, if present, tend to grow to a larger size and become detectable on scans within the first few years after the original diagnosis, where they may appear in the organs where breast cancer metastases are most likely to develop, namely the bones, lungs, liver, brain, and other places. The slide to the right shows the annual hazard of breast cancer recurrence for the four basic types of breast cancer. For the more aggressive, faster growing subtypes like HER2 positive breast cancer and triple negative breast cancers, these are represented by the red and purple curves. The annual hazard of recurrence is highest in the first 2 years after diagnosis and drops after that, although both may have a late peak at 6 to 8 years. For luminal B cancers, represented by the green curve, the annual hazard of recurrence is quite broad, but is highest in the first 5 years. And for the least aggressive subtypes, luminal A, represented by the blue curve, the annual hazard for recurrence is highest in the first 4 years, but tapers off after that. If you're interested in knowing your breast cancer subtype, this slide should give you some idea. The classification is based upon your tumor biomarkers, the estrogen receptor, progesterone receptor, HER2 and Cas7 expression. So if you basically just plug it into the table, you'll figure out what type of breast cancer you have by its subtype, lumen A, lumen B, HER2 enriched, or triple negative. And that'll give you some idea of the recurrence pattern that I just described. So, given the importance of anti-cancer medications for improving breast cancer survival, it is the responsibility of the physician performing the cryoablation procedure or the accountable provider to ensure that the patient understands the risk of distant metastasis and is offered consultation with a medical oncologist for consideration of anti-cancer medications. Appropriate counseling includes clear communication about the role of anti-estrogen therapy for hormone receptor positive breast cancers. It includes counseling about the use of chemotherapy for clinically or genomically high-risk invasive breast cancers, about the role of anti-HER2 therapy for HER2 positive invasive breast cancers, the role of immunotherapy for PD-1 positive triple negative invasive breast cancers, and the role of PARP inhibitors and platinum agents for gene mutation positive invasive breast cancers. If genomic testing has yet to be performed for a patient with a hormone receptor positive HER2 negative invasive breast cancer, it will behoove the cryoablation provider to confirm that adequate tissue is available from the original diagnostic needle biopsy procedure. If necessary, additional needle biopsies of the cancer site may be performed at the time of cryoablation to obtain additional tissue for genomic testing. Historically, breast cancer was routinely managed with upfront surgery followed by anti-cancer medications. However, in the 1980s, studies looking at the pros and cons of giving chemotherapy prior to surgery found that upfront chemotherapy often made the tumor smaller and therefore easier to remove with lumpectomy without compromising overall survival. With regards to triple negative and HER2 positive invasive breast cancer, optimal sequencing of cancer therapy has changed considerably since the 1980s. Recent clinical trials using more effective anti-cancer medications demonstrate that the potential for marked improvement in overall survival with upfront chemotherapy and or anti-HER2 therapy. Therefore, women with triple negative breast cancer greater than 1 centimeter or HER2 or no positive breast cancer should be referred for chemotherapy prior to cryoablation or surgery. For women with HER2 positive breast cancer greater than 2 centimeters or no positive, these patients should be referred for anti-HER2 therapy and chemotherapy. The referral should go to medical oncology. On the other hand, for patients with estrogen receptor or progesterone receptor positive but HER2 negative invasive breast cancer common, these patients should continue to be managed with surgery first in most instances, unless the clinical scenario or genomic information indicates that the patient should receive upfront chemotherapy or upfront anti-estrogen therapy. Of course, patients are fully entitled to decline any of these anti-cancer medications, but failure to inform them and encourage them to consider upfront chemotherapy and or HER2 therapy could potentially leave the cryoablation provider with medical legal liability if the patient has poor outcomes. As I mentioned, upfront anti-HER2 therapy and or chemotherapy for patients with HER2 positive and triple-negative breast cancer has several important advantages compared to post-cryoablation or post-surgery treatment. Most importantly, upfront treatment with these medications has a higher potential to improve patient survival. Upfront treatment also has potential to shrink the tumor or clear cancer from lymph nodes, which can potentially make subsequent surgery less burdensome. But more importantly, significant shrinkage or clearance of cancer in the breast or lymph nodes is a strong indication of a similarly good response in distant organs where microscopic tumor cells might be present, such as in the liver or lung. Equally important, upfront treatment identifies patients with cancers that are incompletely responsive to anti-HER2 therapy and or chemotherapy. For such patients, there may be additional anti-cancer medications that can improve their survival once it is recognized that the initial course of therapy was not completely adequate. However, we would not be able to identify these patients, these incomplete responders, if we had already removed their tumor prior to administration of chemotherapy or prior to administration of anti-HER2 therapy. So, one benefit of leaving the tumor intact for these particular cancers is that you can see how it responds to drug therapy and then decide to give additional therapy or not, depending upon whether or not there is residual disease present after completion of upfront chemotherapy or after completion of upfront anti-HER2 therapy. What you see is that there are remarkably high rates of pathological complete response when any of these chemotherapy regimens are provided. These regimens that are listed include both chemotherapy and anti-HER2 therapy, what we call immunotherapy. And although the results are high for all groups, you see that patients that are ER and PR negative have the highest response rates. In fact, for one drug combination, what we call the TCPH regimen, 81% of the patients had no residual cancer found in the breast or lymph nodes when the patient went to surgery to have those areas removed. 81%. And even those that had some residual disease had a significant response. They had a smaller volume of disease, even though it wasn't completely eradicated. But these are dramatic results for patients that have received one of these regimens, for diagnosis of HER2 positive breast cancer. Now, the second study that's worthy of mention is called the Neosphere trial. This was a trial that was similar to the Trifina trial in that it was a trial of patients with no positive or advanced HER2 positive breast cancer. These patients were also treated with upfront anti-HER2 therapy and or chemotherapy in 4 various combinations, followed by surgery of the breast and lymph nodes to see how effective the drugs were at clearing cancer from these sites. The specific goal here was to determine the pathological complete response rate. However, in this study, some of the chemotherapy was given after surgery, whereas in the Trifina trial, all the chemotherapy was given before surgery. So in the Trifina trial, it was expected that the response rates would be higher. But again, in the Neosphere trial, some chemotherapy was potentially given up front, the rest was given after surgery. But what you see, importantly, is that although there is response, there's a modest PCR rate for every category of patients. For those that received the antibodies alone, Perjeta and Herceptin, but no chemotherapy, although there was a response amongst those patients had the lowest rate of response, regardless of their hormone receptor status. So, although some patients refuse chemotherapy and are willing to take the antibodies because they perceive the risk of chemotherapy to be too great, they must recognize that the best outcomes with anti-HER2 therapy treatments are observed in those that receive chemotherapy in combination with antibodies, not just the antibodies HER2 and Perjeta, just not the antibodies Herceptin and Perjeta by themselves. So again, even though there is a response to PCR rates in the 2 to 20% range for patients treated with just the antibodies, the PCR rates are higher in both instances when those drugs are combined with one chemotherapy regimen or another. Now, although patients with upfront or preoperative anti-cancer medications have been excluded from most cryoablation clinical trials, in my opinion, upfront anti-HER2 therapy or upfront chemotherapy should not contraindicate or prevent patients from undergoing cryoablation as long as certain considerations are addressed. If biopsy site markers are not already present at all sites of cancer, patients should undergo placement of one or more biopsy site markers in the breast and or lymph nodes prior to initiating upfront anti-HER2 therapy and prior to initiating upfront chemotherapy to document the site of the breast cancer in the event that the cancer is no longer detectable on imaging after treatment with these anti-cancer medications. And given the high rate of pathological complete response, particularly for HER2-positive breast cancers, there is a high chance that there will be no visible cancer left when anti-HER2 therapy is completed. Therefore, it's imperative that markers are placed before the therapy is initiated. Whereas a single marker might be sufficient to document the site of smaller stage 2 tumors, larger tumors would benefit from placement of multiple biopsy site markers to outline the margins of the tumor. In addition, placement of a biopsy site marker at the time of lymph node biopsy will facilitate its identification if the lymph node appearance returns to normal after chemotherapy or after anti-HER2 therapy. Here is a breast MRI showing an example of complete disappearance on imaging with a visible tumor and a visibly abnormal lymph node before chemotherapy, shown in image to the left, and the same patient with chemotherapy showing no detectable disease in the breast axilla in the image to the right. This is what we call a complete clinical response. In order to determine if she has had a pathological complete response, she must undergo surgical removal or biopsy of both sites to document that no microscopic disease remains. But in either case, it's still a great response. Here's another patient who has had a great response to upfront chemotherapy. If not for the biopsy site marker, you'd be unable to locate the site of the cancer. The teaching point here is that if a patient were to undergo cryoablation, she would have benefited from having placed 2 bracketing biopsy site markers at the outer edges of the tumor, which are shown here as X's, to document the span of the original cancer so that the entire span of the original cancer could be ablated. Why is ablation of the entire span important? Although a tumor might shrink dramatically during upfront chemotherapy or during upfront anti-HER2 therapy, there is a possibility that microscopic clusters of invisible cancer cells might survive the drug therapy and persist where there was once an obvious visible tumor. To avoid leaving residual cancer cells inadequately treated, it is recommended that cryoablation be directed to the original pre-chemotherapy tumor volume rather than just the post chemotherapy tumor volume. This principle of treating the original spread of disease is different from how we manage surgery patients after upfront chemotherapy or upfront anti-HER2 therapy. For lumpectomy patients, the ability to perform microscopic examination of the surgical margins after surgery allows the surgeon to initially excise a much smaller volume of tissue to see if any surviving cancer cells remain. If cells remain and if the margins are positive, the surgeon can always take the patient back to surgery to remove additional margins or to perform a mastectomy. Since no margins can be assessed after cryoablation, we cannot accept the risk of undertreating the cancer, and therefore it is safer to ablate the original volume plus the surrounding margin of normal tissue. Although the plans for patients treated with upfront chemotherapy should be to ablate the original volume of disease detected on imaging, these patients should still undergo multiple needle biopsies of the original cancer site to document the presence or absence of residual disease as a means of assessing the effectiveness of upfront chemotherapy and or anti-HER2 therapy, and to determine if the patient is a candidate for additional anti-cancer medications, if such medications exist. Given the importance of this information, the cryoablation provider should seek the patient's consent to obtain additional needle biopsies of the original tumor site to determine the presence or absence of residual living cancer cells. In part 1 of the presentation, I discussed the advantages of placing ultrasound visible markers to facilitate ultrasound-guided cryoablation. There's one catch. The preferred ultrasound visible biopsy site markers have an absorbable part made of collagen or hydrogel that is ultrasound visible, and a second metallic part made of titanium or steel that is visible on mammography but not visible on ultrasound. Although the absorbable component of the marker facilitates ultrasound-guided cryoablation, the absorbable component might dissolve and may no longer be detectable by ultrasound by the time the patient is ready for cryoablation after completing upfront chemotherapy. Consequently, these markers typically dissolve over 3 to 4 months. Consequently, the most practical approach for this scenario is for the patient to have the standard non-ultrasound visible markers placed prior to upfront chemotherapy or prior to upfront anti-HER2 therapy, followed later by the adjacent placement of one or more ultrasound visible markers in the breast prior to cryoablation. So let's briefly discuss one of the most exciting yet most uncertain topics related to cryoablation, and that's the abscopal response. The potential for cryoablation of a cancer in one part of the body to induce an anti-cancer immune response to similar cells in another part of the body is called the abscopal effect. Conceptually, an abscopal response occurs when natural immune cells that arrive to clean up dead cancer tissue in one place induce a generalized total body anti-tumor immune response that prevents growth or causes regression of similar cancer cells at other sites. Although numerous well-controlled animal studies have demonstrated the ability of cryoablation of a cancer in one site to prevent growth or induce regression of a cancer in another site, in recent medical literature, there is only one case of a breast cancer cryoablation-induced abscopal event in humans. This was in a woman with stage 4 breast cancer whose positive axillary nodes and distant metastasis regressed after she underwent cryoablation of a primary breast cancer in the breast. However, this case of an abscopal effect or of an abscopal response is against the backdrop of many women who have experienced development of positive nodes or the development of distant metastasis after cryoablation of the breast, especially amongst those that have refused other forms of therapy like chemotherapy or radiation therapy. In fact, in a systemic review of all medical literature published between 1969 and 2014, only 46 documented cases of an abscopal effect was reported. nearly all of which were observed following radiation treatment of melanoma, gallbladder cancer, and kidney cancer. Based upon this limited human experience, and based upon ongoing research, it appears that the best predictors of a potential abscopal response in humans is the presence of an abundance of natural immune cells, including T cells, in the vicinity of the cancer. Another important predictor is the presence of PD-1 checkpoint proteins on T cells. These PD-1 checkpoint proteins are important regulators of the immune response. The prevalence of T cells and PD-1 checkpoint proteins in melanoma and kidney tumors likely explains why the abscopal response has predominantly been seen in these cancers. On the other hand, with the possible exception of triple-negative and HER2-positive breast cancers, the generally low levels of expression of T cells and a generally low level of expression of PD-1 protein likely accounts for the rarity of cryoablation-induced abscopal response in humans with breast cancer. In my opinion, to some degree, I think the prospect of an abscopal response has been a disservice to women as well as to the field of breast cancer cryoablation. The reason for this statement is that the belief in the abscopal response encourages many women to refuse possibly beneficial anti-cancer treatments based upon their refusal is often based on the belief or the anticipation that the abscopal effect will eliminate the need for chemotherapy or eliminate the need for anti-estrogen therapy or eliminate the need for anti-HER2 therapy or eliminate the need for radiotherapy. And, the history that I just shared with you tells us that none of that is really true. Now, while I definitely respect and will accept the woman's ultimate decision about how she wishes to care for her body, it's also my ethical responsibility to point out that the decision to refuse other forms of standard cancer therapy causes many cryoablation patients to needlessly experience higher rates of recurrence in the breast, lymph nodes, and elsewhere. And this not only harms them directly, it also undermines the confidence in cryoablation in the medical community, which can end up depriving other women the opportunity to have cryoablation in the future. In particular, the belief and or hope for an abscopal response has encouraged some women to decline radiation therapy, which in many cases leaves them with a higher risk of recurrence. Despite its rarity, the strongest evidence demonstrates that the possibility of an abscopal response in humans is the immune-mediated regression of cancer metastasis that follows radiation therapy of the primary cancer. Here are two examples of radiation-induced abscopal response that have been published in the literature. Preliminary studies in animals indicate that the anti-cancer immune response to cryoablation can be enhanced when cryoablation is combined with immunotherapy medications. However, it remains to be determined if in humans if combining cryoablation with immunotherapy is capable of stimulating a strong enough immune response to induce an abscopal effect. I got a little ahead of myself, but I'm going to just describe this slide before moving on and emphasizing that point again. You have here a PET scan, two examples, two patients with PET scans performed pre-radiation and post-radiation of the breast. Second is the same, and all of those dark spots you see kind of scattered about the body, the chest and abdomen, are breast cancer metastasis, which you see on the post-radiation image have completely disappeared. There is some residual contrast or tracer in the bladder. You see that on all the images. That's just a normal expected finding on a PET scan. But looking at the region of the lung or liver or abdomen, you see in the second image that there's, virtually no uptake. in the second image, there is some activity in the abdomen, but that's within the colon, and it also is considered to be normal. But the liver looks normal, the chest looks normal, and the pelvis otherwise looks normal. And so again, this response occurred in response to radiation of the breast tumor, and this is really an impressive finding that seems to be a relatively rare event in breast cancer. Now, as I was mentioning, preliminary studies in animals indicate that the anti-cancer immune response to cryoablation can be enhanced when cryoablation is combined with immunotherapy medications. However, it remains to be determined in humans if combining cryoablation with immunotherapy is capable of stimulating a strong enough immune response to induce an abscopal response. Presently, there's only a single U.S.-based human clinical trial investigating the survival impact of combining cryoablation and immunotherapy. Here's the study's identifiers at clinicaltrials.gov. The clinical trial is a phase 2 study of perioperative ipilimumab, or Yervoy, plus nivolumab, or Opdivo, in patients with triple-negative invasive breast cancer who have persistent disease remaining in the breast after already completing upfront chemotherapy regimens containing paclitaxel or docetaxel or Abraxane. All patients in the study received cryoablation of the residual breast tumor, followed by a 5-day course of Yervoy and Opdivo combined. They subsequently undergo a needle biopsy of the cryoablation site, and this is followed 7 to 10 days later by lumpectomy or mastectomy. After surgery, the patients will receive Opdivo every 2 weeks for 3 additional doses. All lumpectomy and mastectomy specimens will be evaluated to measure the immune response. Patients will also be monitored for 3 years to determine their breast cancer survival rates and overall survival rates. In summary, clearly much remains to be learned about how to optimize the likely synergy between cryoablation and immunotherapy in humans to promote a beneficial anti-immune response, particularly the abscopal response. However, in the absence of documented abscopal events in humans and in the presence of potential harmful side effects of immunotherapy, patients should beware of cryoablation providers who tout the abscopal response or freely offer immunotherapy at the time of cryoablation outside of a formal IRB-approved clinical trial. Now let's discuss the more traditional role of radiation therapy or radiotherapy. Recurrences of breast cancer in the breast is a well-recognized risk of breast conservation or lumpectomy. The same thing is true with cryoablation. Consequently, radiation therapy is generally recommended after lumpectomy or cryoablation to reduce the risk of recurrence arising from microscopic cancer cells that may persist in the perimeter of the tumor despite having normal appearing scans, or after lumpectomy despite having negative surgical margins. Although the goal of lumpectomy and cryoablation is to treat the tumor as well as the surrounding rim of normal tissue, even when negative margins are achieved, additional disease may remain behind, which is why radiation therapy has any benefit at all. It is treating disease that we miss because it was not detectable by imaging or not detectable by the pathologist. Now, one of the appropriate and classic criticisms of cryoablation is that it does not permit the assessment of surgical margins. However, let's take a look at the standard process of checking margins after lumpectomy. In the typical case, the pathologist would take a lumpectomy specimen, which is about the size of a small boiled egg. They bread loaf or slice the egg by cutting it into 8 to 10 slices, and then they focus on the slices that contain the yolk, which represents the cancer in this example that I'm providing. They then examine microscopic areas at the surface or edges of several, but not all, of the slices. And if no yolk or cancer is seen at the edge of the slice, they then issue a report that the margins are negative. In many cases, the other slices aren't checked at all. Now, this process of sort of, looking at the specimen in a very limited way is not that they don't care. Frankly, it just takes too long, or would take too long, to evaluate the entire marginal surface of the typical lumpectomy specimen. It would also be too expensive. But they're counting on the fact that radiation will usually be given to clean up any areas that are missed by imaging or missed by them. But when you quantify how much of the actual specimen surface they truly examine, it comes out to be about 1% or even less for larger tumors. So if you're comparing 1% of margin assessment for lumpectomy to 0% actual margin assessment for cryoablation, in the big scheme of things, there really isn't much a difference between the two, 1% or 0%. That's why radiation has a role, because it aims to treat things that we don't assess with surgical margin analysis, or things that we don't ablate because they're undetectable and not targeted for cryoablation. So let's take a look at how radiation therapy can kill hidden cancer cells. For that, we can look at the landmark study conducted in the U.S. Although this study was conducted in the U.S., it was confirmed by 6 additional long-term international studies. The U.S. study was called NACVP B06, which compared women treated with mastectomy to lumpectomy versus lumpectomy and radiotherapy. There were 3 study groups. Patients were randomly assigned to each of the groups. Those treated with lumpectomy all had clear margins. That was one of the requirements. This study enrolled patients from 1976 to 1982, and the patient outcomes were tracked for more than 15 years. First of all, although local recurrences were higher in the lumpectomy groups compared to the mastectomy group, there was no survival difference between the 3 groups, which is why we can ethically offer women lumpectomy instead of mastectomy, because we understand that treatment decision will not compromise their overall survival. That practice is derived from this trial. But what I want to focus on here is the lumpectomy versus lumpectomy radiotherapy group, because that's relevant to the current discussion. The data, outcome data for the trial is shown here. The 10-year local recurrence rate is included for patients with no negative disease, and the 15-year local recurrence rate is included for patients with no positive disease. In the lower part of the slide, the recurrence rates are stratified by age. So as you can see, when you compare, patients based on age or based upon no positive, no negative status, what you see in all cases is that the addition of radiotherapy to lumpectomy reduced the local recurrence rate by approximately 70%, say from 30 to 10%. That's a 70% reduction, or 45 to 13% for no positive patients. And the truth is also this, and that reduction, that 60 to 70% reduction, was also observed within each stage group. So how is radiation doing this? Again, it's doing it by killing macroscopic tumor cells, mostly in the area of the original cancer, that were not detected by imaging, not removed by the surgeon, and are not detected by the pathologist. But again, radiation worked in this study because it treated unrecognized disease that was not detected by imaging, not removed by the surgeon, and not detected by pathologists. Now, over the years, the local recurrence rates have come down for breast cancer surgery because generally imaging is better. We can find patients with occult disease, disease that might have been missed by older mammograms and older imaging. Those patients are now identified. Either they don't undergo lumpectomy, or the lumpectomy is done differently to accomplish removal of these other areas. And so, generally speaking, we're seeing recurrence rates after lumpectomy in the 10 to 20% range over 15 years, not in the 40% range over 15 years. But, the take-home message is that regardless of the starting level of risk, whether your risk is high or low, adding radiation to it reduces that number by about 60 to 70%. When radiation therapy is administered after cryoablation, it should generally be expected to be given in a way that is similar to those that receive radiation after lumpectomy. Radiation therapy typically consists of a 4 to 6 week course of daily radiotherapy doses, what we call daily fractions, which are administered to the entire breast. Around the world, the vast majority of women treated with radiation therapy after cryoablation have received the standard 6-week course of radiation therapy with no significant adverse side effects. However, the newer standard for breast cancer radiation after lumpectomy is a shorter 4-week course of therapy, what we call hyperfractionated therapy. Although there is relatively little experience using hyperfractionation or the hyperfractionated regimen in patients treated with cryoablation, it's reasonable to expect that cryoablation patients should also be treated with the same abbreviated schedule. And so cryoablation, followed by hyperfractionation, meaning the 4-week course, should be the first option considered for these patients. Although I am an expert in intraoperative therapy, patients treated with cryoablation are not candidates for intraoperative therapy because intraoperative therapy requires a lumpectomy. However, some patients that are eligible for RT are also eligible for cryoablation, and so patients sometimes have to make a choice between either undergoing a lumpectomy plus RT versus cryoablation. Now, the purpose of RT is to extend the margins to a greater volume to treat hidden disease that surrounds the lumpectomy cavity. For a tumor about 1 centimeter in size, we can usually ablate about a 1 centimeter margin. And so, what you see essentially is that if the tumor is small enough, the amount of volume you can treat with lumpectomy and intraoperative therapy approximates roughly the amount of tissue that you would ablate if the patient underwent ablation. So the tissue volume treating is about the same. The margin width beyond the cancer is also about the same. So my thoughts are, if the patient has a tumor under 1 centimeter, they are likely to achieve the same cancer control if they're treated with cryoablation or they're treated with intraoperative therapy or lumpectomy. For these cryoablation patients with tumors under 1 centimeter, I do not routinely recommend whole breast radiotherapy, since the amount of margin I can ablate around such a small cancer gives me the same amount of treated volume that I would have achieved had I offered that patient intraoperative radiotherapy. Lumpectomy patients treated with whole breast radiation therapy are sometimes administered an additional targeted dose of radiation to the surgical margins called a boost, in an effort to further reduce the risk of recurrence. No consensus exists regarding the need for a radiation therapy boost amongst patients treated with cryoablation. It would be illogical to assume that all patients treated with cryoablation will require a radiation boost simply by virtue of having undergone cryoablation. Though radiation boosts are potentially effective at reducing the local recurrence rate, routinely adding a radiation boost would increase the cost of care and potentially worsen breast cancer cosmesis, like greater degree of fibrosis, greater degree of skin pigmentation changes, or a phenomenon called telangiectasias, where abnormal blood vessels form in the skin. These are potential consequences of having higher doses of radiation that you would get, say, with the boost. So without a clear benefit of adding the boost, one should generally avoid it. Uh, However, a more rational approach would be to limit the use of radiation boosts post-cryoablation to situations where the medical evidence more strongly supports the use of radiation boost after lumpectomy, namely women under the age of 50 or women aged 51 to 70 with high-grade tumors. The presence of positive lumpectomy margins is also another reason for patients to be offered a radiation boost. However, the inability to assess surgical margins following cryoablation should not lead to the assumption that the ablation margins are positive and therefore should require a boost. Fortunately, there are low-risk situations for which no radiation is needed. One trial that demonstrated this was CLGB 9343, which was a randomized controlled trial which demonstrated minimal radiation therapy benefit in women aged 70 years and older with stage 1, grade 1 or 2 estrogen receptor and/or progesterone receptor positive HER2 negative invasive breast cancer who were treated with anti-estrogen therapy. A second recently presented study, the Lumina trial, was a non-randomized trial which also showed minimal radiation benefit in women aged 60 and older with stage 1 estrogen receptor positive and or progesterone receptor positive HER2 negative low risk luminal A type invasive breast cancer. This was true when the patients were willing to take anti-estrogen therapy. Therefore, in these patient populations, it is also reasonable to conclude that radiation therapy would similarly have minimal impact on local control after cryoablation among patients who have agreed to take anti-estrogen therapy. Although there are multiple genomic assays to assess the total body risk of recurrence after a diagnosis of invasive breast cancer, there are currently no validated commercially available genomic tests for estimating the risk of local recurrence after lumpectomy for invasive breast cancer, specifically invasive breast cancer. However, the 10-year risk of recurrence amongst patients with early-stage breast cancer can be estimated to a reasonable degree by using the online tool IBTR 2.0, which can be found at the link which can be found online by searching for IBTR 2.0. This tool integrates 7 different variables: age, tumor size up to 10 centimeter, tumor grade, margin status, the presence of lymphovascular invasion, use of chemotherapy, and use of anti-estrogen therapy to estimate the relative benefit of radiation therapy and the relative benefit of anti-estrogen therapy. A key shortcoming of this tool is its tendency to overestimate the risk of local recurrence, a limitation that is perhaps less hazardous than if it underestimated the risk. Additional shortcomings include the lack of utility of this tool for women with triple-negative breast cancer and HER2-positive breast cancer. The tool also is not useful for people with multifocal, multicentric, or recurrent breast cancer. Nonetheless, the online calculator does provide a means of assessing local recurrence rates for the majority of women diagnosed with early-stage breast cancer today, namely those with unifocal, hormone-sensitive, HER2-negative invasive breast cancer. With a relatively clear estimate of the rate of risk of local recurrence, these patients will be able to more fully make an informed decision about the use of radiation therapy and anti-estrogen therapy. Again, this is an online tool which you can use yourself. Just look for it online at IBTR 2.0. Although there are no commercial tests available for looking at local recurrence for invasive breast cancer, that's not true for patients with DCS. In fact, there are 2 commercially available genomic tests, DecisionRT and Oncotype DX breast DCS score. which are used for estimating the 10-year risk of breast cancer recurrence with and without radiotherapy in women with ductal carcinoma in situ. Decision RT is validated for women age 30 and older with DCS measuring up to 7 centimeters. Oncotype DX DCS score was validated for women age 18 years and older with DCS measuring up to 2.5 centimeters. Although these tests were not validated in patients treated with cryoablation, one can reasonably infer that the tests would be applicable for estimating the benefit of radiotherapy in comparable women treated with cryoablation. Here's an example of a DCSR Decision RT test result showing an overall risk score, showing an overall risk score based upon a scale of 0 to 10. This particular example shows a patient who has an elevated risk of 8.3 out of 10. The 10-year risk of recurrence of DCS or invasive breast cancer with and without radiotherapy is shown in the lower left. The slide also shows the 10-year risk of invasive breast cancer with or without radiotherapy. So you can estimate the overall rate of recurrence regardless of whether or not it's invasive or DCS, or if you're only interested in looking at the risk of having a recurrence of invasive cancer, again, that's separated out, and you can look at that in the lower right of the image. Again, in this example, this patient had over 10 years a 37% risk of having a recurrence of invasive cancer or DCS without any radiotherapy. If radiotherapy were added, it is estimated that her 10-year risk would be reduced from 37% to 11%. Again, a 70% reduction. If you look at only her invasive cancer risk, over a 10-year period, she still had a fairly high risk of invasive cancer, 29%, when treated with lumpectomy alone. However, when radiation was with radiation added, the local recurrence risk would be reduced from 29% to 9%. Again, a 70% reduction. So the point here is that this tool allows you to estimate that 10-year risk of recurrence and make a decision about whether or not the impact of radiation therapy is significant enough to make it considerable, to make it a reasonable consideration for a patient with DCS. The final topic that I will cover is follow-up after cryoablation. Currently, there is no standard post-treatment follow-up protocol for patients treated with cryoablation. At a minimum, one can expect cryoablation patients to undergo annual clinical breast examination and annual mammograms in keeping with the standard protocol followed by patients treated with lumpectomy. Annual mammograms will be supplemented with ultrasound or contrast-enhanced breast MRI or thermography, depending upon the clinical findings, breast density, risk factors, patient preference, and features of the original cancer. Some patients may refuse to undergo mammography and contrast-enhanced MRI due to concerns about radiation or gadolinium exposure, and may require a more customized post-cryoablation imaging routine. Regardless of the regimen, the purpose of follow-up imaging is to detect residual or recurrent breast cancer, which are detected most often in the region or perimeter of the original cancer. Nonetheless, tissue changes within the zone of inflammation, combined with the usual difficulties of detecting microscopic disease, frequently justifies routine image-guided biopsy to exclude recurrent or residual disease. A key remaining challenge with the imaging follow-up of a cryoablation patient is a relative lack of experience nationally amongst radiologists in interpreting post-cryoablation imaging studies. For cryoablation patients, the imaging learning curve echoes the experience that many radiologists shared in the early days of lumpectomy, when radiologists had to gain experience and confidence in interpreting the imaging findings of patients treated with lumpectomy and radiation therapy. As expressed in one medical journal article, interpretation of mammograms after lumpectomy requires knowledge of the mammographic pattern of breast cancer and scar formation, an appreciation of the alterations that occur in the mammograms after breast radiation, and an understanding of the benign changes that can mimic new cancers in women. This journal article was published in 1995. The very same remarks can be applied to cryoablation today. Meanwhile, patients managed with cryoablation may have to travel to breast imaging centers with greater expertise in performing and interpreting post-cryoablation imaging studies, especially for the initial set of post-cryoablation studies, which are the most challenging ones to interpret. These initial studies will constitute or establish a new baseline against which subsequent imaging studies can be made or compared. These initial studies will constitute or establish a new baseline against which subsequent imaging studies can be more easily compared. Of course, travel may be a luxury to many patients. Those unable to travel may choose to have their post-cryoablation imaging studies performed and interpreted in their home community, but later have them sent for independent second opinion by a radiologist more familiar with interpreting post-cryoablation imaging studies. For accurate interpretation, radiologists will need to compare the post-cryoablation imaging studies to the most recent set of pre-cryoablation imaging studies. So patients would have to provide both the post-cryoablation studies and the pre-cryoablation studies for a proper imaging interpretation. Mammographically, the cryoablation site is typically characterized by a thin spherical scar or cryoball that roughly corresponds to the size and shape of the ice ball that was created at the time of the cryoablation procedure. The cryoball is more apparent in fatty breasts and more subtle in dense breasts. Another common mammographic feature of a cryoablated mass is a tumor ghost, which is a visible remnant of the dead cancer mass that disappears over time. Here's an example of a patient who completed neoadjuvant chemotherapy with disappearance of most of the disease except for one visible mass. She underwent ablation of the original span of disease, requiring 8 ablations. In this example, you can get the impression of multiple overlapping ablations and a ghost tumor that was corresponding to the residual mass. So here's the areas of overlapping ablation. You can kind of see these overlapping concentric areas, and again, that was the ghost tumor that persisted post-cryoablation but was also present pre-cryoablation. Although the tumor ghost is expected to gradually disappear, microcalcifications associated with the malignancy are expected to remain in place even when the surrounding cancer cells have been completely killed. In essence, microcalcifications are fossils of dead cancer cells that have become calcified and stone-like, and as such are not digestible by the immune cells, but also not capable of growing. On the other hand, the appearance of new microcalcifications within or in the perimeter of the cryoablation zone could indicate the presence of recurrent disease. However, most often, developing microcalcifications or macrocalcifications, large calcifications, indicate the presence of fat necrosis, which is a common feature of dying fat tissue that has lost its blood supply due to surgery, cryoablation, and or radiation. In either case, a stereotactic or mammographic-guided needle biopsy might be needed to distinguish between cancer recurrence and fat necrosis. Despite the frequent use of ultrasound to examine the cryoablation site, the presence of a ghost tumor and the typical tissue distortion caused by the cryoablation procedure make it particularly difficult for ultrasound to detect residual or recurrent tumors within the cryoball. However, unlike mammography, where the edges of the cryoball might be difficult to detect in patients with dense breasts, ultrasound of the cryoablation site consistently demonstrates a distinct hyperechoic border corresponding to the edges of the cryoablation site, and this is true irrespective of breast density. Here you see that very sharp edge between the cryoablation site here and the surrounding tissue. Ultrasound can also detect new hypoechoic masses at the perimeter of the cryoball, like in this area here, that might indicate the presence of recurrent disease. Here's an ultrasound of a much larger tumor spanning 8 centimeters that was treated with cryoablation. You can see the borders of the cryoablated area shown here. Before I move on from that image, I just want to make the point here that this is a pre and post cryoablation study. This is pre-cryoablation. This is 3 years post-cryoablation. The patient had a tumor in the upper outer aspect of the right breast shown here. This is pre-cryoablation. 3 years post-cryoablation. There's no enhancement at all, and there's no visible ghost tumor in the on this breast MRI image. Now, for tumors near the chest wall, the adjacent muscle commonly exhibits various degrees of inflammation, indicative of what's called the thermal burn or thermal injury, which should not be assumed to be an indication of muscle invasion. It's just that the muscle was temporarily frozen. The burn typically resolves over 6 months and produces no lasting physical limitations. Temporary muscle weakness or stiffness will improve with time, stretching, and possibly weight training. Depending on the clinical stage, FDG PET-CT may sometimes be performed to rule out or assess the extent of distant disease. Although PET-CT scanning generally has poor resolution for breast anatomy, fat necrosis inflammation at the cryoablation site can produce a low level of activity on PET-CT that might be difficult to distinguish from recurrence or residual cancer. Among patients undergoing PET-CT within 12 months of cryoablation, one study reported a median maximum standard value unit, that's FUV max, of 1.36. In general, the SUV max was significantly higher in young women, significantly higher in premenopausal women, and also higher in women with high breast density. Despite its ability to completely exclude recurrence, despite its inability to completely exclude recurrence or residual disease, PET-CT might demonstrate loss or decrease of activity at the cryoablation site that is highly suggestive of a positive response or of an effective cryoablation response. For example, in the image shown here of this PET-CT performed 1 month after cryoablation of a 3 centimeter ER-positive, PR-positive, HER2-negative invasive breast cancer. This is an image of a patient who underwent cryoablation of a 3 centimeter tumor. As you see on this PET-CT image, the white area that is shown here, which was a site of the cancer, shows minimal FDG PET-CT activity compared to the background level of activity seen in the remaining breast. So the fact that there's so little activity here is a really good indication that there's minimal that there's minimal chance that there are surviving cells within this area. Depending on the clinical stage, FDG PET-CT may sometimes be performed to rule out or assess the extent of disease. Although PET-CT scanning generally has poor resolution for breast imaging, fat necrosis and inflammation at the cryoablation site can produce a low level of activity on PET-CT that might be difficult to distinguish from recurrence or residual disease. Among patients undergoing PET-CT within 12 months of cryoablation, one study reported a median maximum standard value unit SUV max of 1.36. In general, the SUV max was significantly higher in younger women, premenopausal woman, and a woman with high breast density. Despite its inability to completely exclude recurrence or residual disease, PET-CT might demonstrate loss or decreased activity at the cryoablation site that is highly suggestive of a positive response. For example, this image shows the PET-CT of someone who underwent cryoablation 1 month earlier. She underwent cryoablation of a 3 centimeter ER positive, PR positive HER2 invasive breast cancer in the upper outer breast. The white area shown here on the image demonstrates significantly reduced FGG PET activity at the cryoablation site, which suggests that there's no living cells in that location, especially given how it contrasts with the surrounding breast tissue, where the background activity shows some level of activity. So the fact that there's no activity here suggests that this tissue here is less metabolically active than the surrounding tissue. Again, an indication of a good response post-cryoablation. Or it's an indication of an effective cryoablation procedure. Routine needle biopsy of the cryoablation site plays several key roles in the follow-up and management of the cryoablation patient, and may be performed under ultrasound, mammogram, or MRI guidance depending upon the characteristics of the cancer. For all patients, a benign needle biopsy will confirm the absence of residual or recurrent disease at the cryoablation site. For the patient and provider, a benign needle biopsy result allays concerns about the dominant breast lump or cryoball that naturally forms after the cryoablation procedure and persists for years. For a radiologist, a benign needle biopsy result supports downgrading of the radiologist's impression from BI-RADS 6, which indicates mammographically that the cancer is likely still present, to a score of BI-RADS 2 or 3, indicating a benign finding for which post-treatment follow-up imaging is recommended. For the radiation oncologist, a benign needle biopsy result confirms the absence of residual disease before initiating breast radiation therapy. Here's a pre- and 3-year post-cryoablation breast MRI showing no residual mass. I mentioned that previously. This same patient underwent a core biopsy of the cryoablation site 6 months cryoablation, and the pathology results showed fibrosis, chronic inflammation, fat necrosis, but no evidence of residual malignancy. Here's a needle biopsy needle biopsy breast pathology performed 6 months after cryoablation of a patient who underwent 8 cryoblations after completing neoadjuvant chemotherapy. Similar to the previous example, the patch showed necrotic tissue, fibrosis, chronic inflammation, calcifications, but no evidence of residual cancer. For reasons that I already discussed, it is a reality of breast oncology that a subset of patients treated with cryoablation, or lumpectomy for that matter, will experience a recurrence of breast cancer within the breast. The potential of recurrence within the breast is particularly relevant for patients with a high risk of disease who decline radiotherapy. Like the risk of distant disease, recurrences within the breast are more likely to develop within the first 2 to 4 years after cryoablation. In most instances, local recurrences will arise in the perimeter of the cryoablation tumor, cryoablated tumor, outside of the cryoablation zone of necrosis, in tissue that appeared normal at the time of cryoablation, but in retrospect contained microscopic disease. Local recurrences leave the patient and her provider with a new healthcare decision about how to manage the recurrence. Fortunately, patients that experience the local recurrence after cryoablation generally retain all the same treatment options that they had before cryoablation. They can have mastectomy, they can have lumpectomy, or they can have repeat cryoablation targeting the recurrence. If the patient had declined anti-estrogen therapy or had declined radiation therapy following the initial diagnosis of cancer, she should be encouraged to reconsider anti-estrogen therapy or radiation therapy after cryoablation of the recurrence. In summary, cryoablation is emerging as a minimally invasive alternative to breast-conserving surgery for the management of breast cancer. Despite the advantages of cryoablation as a minimally invasive procedure, patients seeking cryoablation must often navigate themselves along a complex cancer journey without the steadfast guidance and support of an expert breast surgeon, surgical oncologist, or medical oncologist, or a cancer team. Consequently, cryoablation patients may fail to benefit from essential cancer management practices that are critical for successful outcomes. The purpose of this guideline is to discuss important management practices and quality measures that should be considered for all breast cancer patients, regardless of how their breast is managed. The guideline also stresses the importance of having an accountable provider or providers who will not only manage the cryoablation procedure, but also help the patient navigate the entire continuum of care. Thank you for your attention and your time to listen to not one but two video presentations. If you'd like to have the print version, once again, it can be found at my website, cryoablation.com. I appreciate your time. I appreciate you. All the best. Have a good day.